And we're going to move now to our clinical topic. I'm very happy to welcome Dr. Lea Al Matny. She is an oral and maxillofacial radiologist from Austin, Texas. She received her specialty training at UTHSC, San Antonio, University of Texas Health Science Center, San Antonio. And she is part of a radiology practice called See-Through Reports. She's also a clinical education specialist for CareStream Dental. So I'm very happy to welcome Dr. Al Matny. She's their first time speaking in our webinar, and I'm going to turn this over to you now.
Thank you so much. It's my absolute honor. Let me share my screen. Okay, you can see the PowerPoint. Okay. Okay, so let's see, 40 minutes. Okay, thank you so much for having me on today. Thank you for attending. I know you already got an introduction. I'm not gonna waste any more time on that. If you want to connect further afterwards, I'm happy to. So what I would like to get out of this next hour is to think about cone beam as a diagnostic tool. So we're used to thinking of using cone beam or using it as an imaging modality whenever we have a tooth that need root canal treatment, or you're thinking it might be fractured, or implant placement, or extracting third molars. So with time throughout the years, we developed certain benefits that certain benefit for cone beams that can impact your treatment plan. What I would like to challenge you with today is to start thinking of it as a diagnostic tool and not just selectively use it in different scenarios, and consider implementing it in your practice as um, uh, as a diagnostic imaging modality. So anytime you need imaging for a new patient exam, I think it's important to pause for a second and think, well, what does this patient eventually need? Will he need implants? Will they need root canal treatment? Are there any surprises within the patient's jaw that I should know about today? And at that point, decide if a full mouth series is more than enough, or do I just take a CBCT scan? So because of that, I'm going to go through, I think, 2 or 3 cases that show the benefits of CBCT simply when it comes to diagnosis and guidance in treatment plan. Regardless of the actual treatment. So whether it's implants, endo, the purpose is diagnosis. I think that case 2 and case 3 are also more focused on the variations of anatomy that we can see within the jaw and can impact your treatment. Second thing we're going to do is look at radiation exposure, because it is one of the most common questions that we get. So at what point is it okay to switch between 2D and 3D? Am I subjecting the patient to more radiation exposure? So we're going to talk about that. And third, we're going to open up a case together and look at how looking at a scan in a comprehensive way will really impact your treatment and also impact the patient at a long term. So just looking overall what's in the patient's jaw and what are the things we should do today versus 6 months versus a year from now. And if you're doing that, using CBCT will add so much more information to you. Okay, so let's start. Case number 1. I got this case, I think it was last year. And the patient had pain in the hard palate, discomfort, and really the pain was more generalized. This was shared to me by the patient's dentist. They did have a history of trauma, and I got the scan after number 8 was already endodontically treated. So the patient had pain, discomfort. I think what she mentioned was number 8 was sensitive to percussion. the pulp vitality test was inconclusive, and the decision was to do root canal treatment on number 8, especially because there's a lesion apical and palatal to number 8. So this was assumed to be a lesion of endodontic origin. When I got the scan, it was the point, this is the scan that I got. It was 6 months after the root canal treatment was done. And the question was more, I did this root canal treatment. This lesion of endodontic origin is not is not shrinking. It is not improving. In fact, I see it become larger. And if we look at this CBCT scan, it might be easy to just like as a quick look to assume this is a lesion of endodontic origin. But if we go back to the basics and we think of what is a lesion of endodontic origin, we need 3 factors radiographically. We need to have a lesion of circular in shape, around the apex of the tooth, and low in density or radiolucent. If we look at this, we do have a circular in shape lesion. It is low in density or radiolucent if you're looking at 2D, but it's not really surrounding the apex of the tooth. If we look at the epicenter of the apex and try to align it with the epicenter of the lesion, you'll see that that lesion is located palatal um, to the root, not just the apex. Now, one thing that I would like to highlight is when the clinician had made this diagnosis, it was based on 2D initially. So the scan was taken after the patient's symptoms were not resolved, after seeing the lesion on 2D become larger. So the scan wasn't taken initially before doing the root canal treatment. That's why I don't have that image. But if we try to make the same diagnosis on periapical X-ray, you'll see that it can be a bit more misleading, and it can be easier to assume this is a lesion of endodontic origin because both epicenters are aligned on top of each other. You have that circular in shape, low in density, and it does look like it's surrounding the apex. So this is one thing where diagnosing with CBCT can be more accurate compared to periapical x-rays. And if you look at this, it's important to look at it in 3 dimensions. So this is the same lesion, this is number 8, and you'll see we have that circle. It's causing expansion of the palatal cortex, interruption, interruption as well. And you can see that it is emerging from the incisive canal. So we now know that the origin of this lesion is not endodontic. It's not related to number 8. It is in fact growing from within the incisive canal, or you might know it as nasopalatine duct. And it is pushing on the apex and the root of number 8. So the incisive canal cyst or nasopalatine duct cyst, it is the most common non-odontogenic developmental cyst. And I'm sure you know more than I do. Like sometimes you will have patients that are symptomatic and where symptoms are suggestive of like that they have an incisive canal cyst. Whereas you might have other patients that are completely asymptomatic, they feel nothing, um, you see nothing clinically, but when you open that CBCT scan and you scroll on axial view, you see that large lesion in the midline of the maxilla. So radiographically, the 3 rules for us to assume or suggest that this is an incisive canal cyst is when you see circular in shape, or sometimes it could be a bit irregular, but it's always well defined. So you will always be able to tell where it starts, where it ends, see that it does originate from the incisive canal. And for the diameter to be larger than 0.6 centimeters, and you should see mass effect on the cortical plates. When you have these 3 factors, it's good to think of nasopalatine duct cyst or incisive canal cyst in your differential. And I'm actually going to just like go out and say it doesn't, if these three exist and you see it from the incisive canal, then it is not just a differential, it is your diagnosis. Now, normally in a healthy patient with no cyst in their jaw, this is what the incisive canal usually looks like. So that incisive canal can vary in shape a bit. You might see it sometimes more slender, more cylindrical. You might see like a small bump at the midline, at the mid height of the incisive canal. But even if there are some variations in shape, the one thing you will not get to is the 0.6 centimeter in diameter. So even in asymptomatic patients and patients who have all their teeth, that incisive canal will always be maybe like 0.2. Sometimes it will be very hard to see, especially in kids, because it would be extremely thin. Now, in completely edentulous patients and in patients who have lost their anterior teeth, sometimes for over a few years, you will see that incisive canal is slowly enlarging. That's why it's more common to have that canal larger in diameter in edentulous patients versus dentate patients. But we can easily, well, sometimes not so easily, but we can distinguish the difference between that variation of normal because of the lack of teeth. So there's not as much pressure on the canal to be restrained anymore compared to in actual pathology, because you won't see any mass effect on the cortical plates. You won't see a ballooned out lesion in the midline of the maxilla. It would just be homogeneous, larger from top, from the floor of the nasal cavity to the oral cavity. So these are just other examples of an incisive canal cyst. And clinically, as we just talked about, it could either be completely asymptomatic, or some of the clinical symptoms that you might see patients are experiencing are just generalized pain, generalized discomfort, burning sensation within the palate, within the maxilla, and more often than not, they cannot tell where it's coming from. They can't really pinpoint it to number 8 or number 9. So these are the symptoms that should get you thinking about an incisive canal cyst. Okay, case number 2. And of course, if you have any questions, please drop them in the Q&A box and we can get to them when we're done. So with this case, number 20. And the tooth is asymptomatic. And the one symptom the patient does have is he had numbness on the lower left side. Now, and this numbness started after the root canal treatment was completed. And after 5 days, we were able to see that numbness localized to where the mental foramen is. Now, before we even look at CBCT or volume renderings, we can see that on this reconstructed PAM, we have a root canal treated number 20, number 19. We can trace the mental foramen and mandibular canal, and we can see there's a small amount of extruded obturation material between the mandibular canal and number 20. Now, when we look at the actual cross-sectional images of number 20, we could see that that obturation material, the extruded obturation material, is really in contact with the mandibular canal. And we have more understanding of why the patient's feeling what they're feeling. Now, the point of me sharing this case and the case right after it is really to focus on the variations of normal that can impact your treatment plan. And these are things we usually do not think about unless we're placing an implant or unless we're extracting a third molar. We don't think about the location of the mandibular canal or the mental foramen with respect to the mandibular molars unless you're placing an implant. But very often does you will find variations of normal that you should consider in your treatment, especially if it's a root canal treatment. Now, the first variation of normal that I'm going to share is the location of the mandibular canal itself with respect to the mandibular premolars and molars. So, by that, I mean, in some patients, you will see the mandibular canal just course inferiorly and sometimes very close to the inferior border of the mandible. Whereas in other cases, you will see that mandibular canal in contact with the APCs of the mandibular molars, and specifically first and second mandibular molars, usually more common than the premolar. So there is no rule of thumb of like if the patient looks like this, then it's lower. If the patients look like that, then it is in close proximity. We would have to take a scan and see where the mandibular canal is. And what this patient is experiencing is actually more common than you think. And even if you are using an apex locator, the apex locator sometimes will have an error because it sees or it can detect the cortical plate of the mandibular canal as the edge where you should get to instead of the apex of the tooth. Okay. Second case that talks about variations of normal, and this is the second variation of normal that we can have. And well, first let me talk to you about the case, and then I'll show you what the variation is. So this patient, I actually got this case maybe a year after I think it was 2021. And it was really hard to like go see dentists back then, especially if it's not emergency. I remember this patient going to the dentist over 6 times for the same purpose. And the patient felt numbness within his chin. And that numbness started after placing these two new crowns. So the patient had his crowns placed, and within the next 6 weeks, he kept coming back. And every time there was nothing clinically that could explain the patient's numbness. So if we look at this periapical x-ray, so how I got this case was from the endodontist. So after 6 weeks, the dentist was referred to the endodontist, and the endodontist took this periapical x-ray and the CBCT scan that I'm about to show. And from this x-ray, we can see why the patient might have had pain. So we can see periapical lesion around the mesial distal root of number 19. We see thickening of that lamina dura around the roots. We also see thickening of the lamina dura around the mesial root of number 18, and maybe apical PDL space widening on 18, but like the distal root is cropped, so I couldn't really tell what this is. Now, the scan that I'm about to show you is of that area. So it's a 5 by 5 centimeter CBCT scan. Now, before I play that video, you will see a lot of artifact and movement. And like it was a scan that is harder to read just because the patient moved while taking the scan. And by the time that I got the scan, the patient had already left the doctor's office, and it was good enough. So it is not the absolute best image quality. I would argue it is one of the least like not good image quality that you should expect coming from cone beam. But I still like this case just because it adds so much value and it does affect how we're thinking. So this CBCT scan is the same as this patient. I think they were even taken the same day. Now, when we look at this scan, first we can confirm what we suspected on the periapical x-ray. So we see the periapical lesion around number 19. We also see it around number 18. And you see that thickening of the lamina dura. So I'm going to play that video and you can see the lesions on 19 on 18, but there's something extra that we could detect on the scan that explains the patient's numbness or numbness within the posterior mandible. So as we play that video, yes, I want you to focus on the mesial root of 19. Now, with that mesial root, the one anatomical structure we need to consider in the mandible, in the posterior mandible, is the mandibular canal or inferior alveolar nerve canal. And we can see the canal coursing over here, but at this stage, you see the mental foramen exiting apical to number 19, and you also see it in communication with the lesion. I'm going to replay the video so you can see. So the lesion kept getting bigger to a point where it communicated with the mental foramen, and the patient started feeling that numbness. So now we know why the patient's feeling what they're feeling. If there's anything cone beam can give you, is either if there's anything cone beam can give you, it's assurance on and like more information that can explain the patient's symptoms. Sometimes if we don't know why they're feeling that way, you won't know how to treat them. So that second variation of normal is the location of the mental foramen in the posterior mandible. We have always thought that the mental foramen most of the time exits between the two premolars, but in fact, there's a lot of variability when it comes to that exit. And that variability can vary between the location apical to the mesial root of the first molar all the way anterior to the canine. The second variation that you can see with the mental foramen is the angulation of the mental foramen exit with respect to the buccal cortex. So sometimes you will see it loop backwards, just like B. I know this says that, like this paper, they say that A is more common where it just exits vertically, but I feel like the most common cases that I personally see are the one where the mental foramen loops posteriorly. And what we just saw in the case where we're discussing, I think it was A. So we had a variation of location where the nerve, where the mental foramen exited apical to the mesial root of 19, and it had a vertical direction, which made it much easier to communicate with the periapical lesion. So that's our second variation of normal. Our third variation of normal is the presence of accessory or secondary branches of the mandibular canal. Yes, a lot of time, if not like every time, you will see just two mandibular canals in the posterior mandible. And sometimes you will see bifid mandibular canals. You can see bifid mental foramina. I think I've seen like trifid mental foramina maybe 3 times in the past 40 years. But one variation of normal that we usually do not consider is accessory branches or secondary branches emerging from the mandibular canal. This is different from a bifid mandibular canal because for a canal to bifid, you would have to see that bifurcation and the diameters of both mandibular canals have to be over 50% of the main mandibular canal. So you would see an actual canal exit from it, large canal. Whereas with these secondary branches, the diameter varies from 0.5 to sometimes 2 millimeters. They are very common. So I'm gonna point out the secondary branch in each of the images. So this is one where it runs vertically. This is an image B where you see it loop back towards the distal. And you can see that they do look like canals. They are emerging from the main mandibular canal. They are well corticated. This one has a larger diameter than A. So notice how these two are different. And this one reaches the alveolar crest. You will also see some that reach the apical area of T, which can also explain why sometimes a patient has numbness after, even if you see a periapical lesion, but it's far from the mandibular canal, sometimes having these secondary branches in contact with the APCs can also affect the patient's symptoms. Now, I would have loved to ask you, like, how often do you think you see secondary branches? But usually, like, whenever I use this case, in live sessions, the answer I usually get is, well, maybe 10%. I don't usually look for them. But in fact, if we go back to literature, you'll see that they are very prevalent and they're frequent to a point where, according to the studies that I've looked at, it's between 15 to 65%. And this is a very wide range of percentage between 15 and 65. But it's a wide range, I want to say, because of the exclusion criteria. So some papers will say, I will only count that as a secondary branch if the diameter is larger than 1.5, um, or if it actually reaches a tooth or it reaches the alveolar crest. Whereas others will count any secondary branch that they see, regardless of diameter, regardless of the patient, regardless of whether they have teeth or not. So that's the only reason that I was able to see for that variation in frequency. But I think what's important is for us to scroll back and forth on a scan and see if you see a secondary branch. I don't think it really matters to classify it. I'm just showing this to you as just like for additional information to see like this has been very well documented. Um, but I wouldn't spend time on that classification because at the end of the day, what matters is that if you see it, is it in relation to any of the teeth or edentulous sites that you're working with? And we don't really need it more than that. And a lot of times, I'm glad this was here. A lot of times, you will see it in third molar sites, and you can see it looping around that third molar. Okay, so we finished the cases. I still have one CBCT scan. I would like to open the software and look at it with you. But just as a summary, I know we just talked about 3 cases, but I would really encourage you to use CBCT scan, whether you have it in your office or not, but to think of it as a diagnostic modality, because a lot of times you'll see that it affects your diagnosis and affects the treatment plan. Like there are papers that show 58% of surgeons who use cone beam change their treatment after taking that CBCT scan. And even with the other 42% where you stick with the same treatment you had that was based on 2D, I think it would still be helpful to confirm that your findings or your treatment is in the correct path. I think it just gives you more diagnosis that this is what I should be doing, especially when you see things in 3 dimensions. And some of those incidental findings, uh, yes, you will see mucositis in the maxillary sign. You will see sometimes random incidental findings. But the one incidental finding, which I wish I had more time to talk about, is the presence of root resorption. And there's one type of root resorption, which is cervical root resorption, that is very common. Patients are asymptomatic, and it is very important to either monitor them or to treat them. So cervical root resorption, keep an eye out for them when you take a CBCT scan, because as you scroll up and down, you will see there's a small line, and it's usually not associated with a lesion. Um, there are no symptoms to it unless it reaches that the root canal space. Okay, so radiation risk assessment. Now, if we were to talk about specifically endodontists, for example, or surgeons or periodontists, you would see that each one of these specialty bodies, legal bodies, have guidelines. They have guidelines to when you should be or shouldn't be using CBCT. And especially with endodontists, you'll see that those guidelines, they have bulleted points. 11 out of 14 of the recommendations suggest using cone beam. And the other three are really when the patient is asymptomatic, when you're doing a follow-up, and there is absolutely no reason, not just to not take a scan, but to not do a root canal treatment as well. Now, if we look at this from a more broad perspective, and specifically like when it comes to general dentistry, unfortunately, we don't have a lot of guidance to, if you see the patient having these symptoms, or if you suspect this, then take a scan. If you suspect that, do not take a scan. We do not have this in place right now. I hope the ADA is working on it. But what we do have is an advisory statement from Scientific Affairs, the ADA Scientific Affairs, and that statement was published back in 2012. Now, back in 2012, so this was 8 years ago, and they recommended that you use it at your own discretion. If you feel that cone beam will add to your diagnosis, will affect your treatment plan, it will be helpful for the patient, then feel free to use cone beam. If you do not feel it will be helpful for the patient, then do not use cone beam. So it's really up to you to decide when to take or use a CBCT scan and when not to. But throughout the past few years, we've had a shift in perspective. And that shift is when it comes to the ALARA principle. So for the longest time, we have been using as low as reasonably achievable. And we've started to see a shift when it comes to that principle, especially starting in dental schools and the ones who have a radiology program, where that principle is being shifted to as low as diagnostically achievable, and as long as it's or indication oriented and patient specific. So we want to start using radiographs as a whole and think of them as, is this is this affecting my diagnosis? Is this helping this specific patient? So it's not just about only using that principle for cone beam, it's about full mouth series, bite wings, periapicals, pano, CBCT, which imaging modality fits best in this specific case for what I'm planning to do or for the patient's symptoms. So I think it's easier to develop your own protocol with your team members and say, if we're planning on doing that, you take that CBCT scan with that field of view, with that, with those settings. So, or if not, you have other options as well. And I think this principle came from having radiation exposure parameters closer to each other between CBCT, 3D, and 2D. Because those numbers are now relatively like they complement, they are very similar to each other. You don't have a wide difference between 2D and 3D, then it's easier to set that aside for a bit and only focus on the diagnosis and benefit of the patient. And that radiation exposure will vary depending on not just the machine you're picking or if you're taking a CBCT scan or not, but it does vary depending on the purpose of the study. So if you're taking a high resolution scan and you expect to see signs of a fracture, root resorption, communication with the sinus, then you're going to need a higher resolution. And that effective dose is around 70 microsieverts, 72 microsieverts. Whereas if you're taking a low dose CBCT scan, For example, in this case, a 5x5 low-dose CBCT scan is 10 microsieverts. As a reference, every periapical X-ray is approximately 10 microsieverts or 9.5 microsieverts. Just by existing on this earth, we are subjected to 8 to 10 microsieverts per day. So we don't have anymore that widespread effective dose where we have to think long and hard whether we want to use CBCT or not. You see that those numbers will vary based on field of view, the parameters you're using, or even like the size of the patient. So this is a table that was published by Dr. John Ludlow. He is an oral maxillofacial radiologist. He has been a faculty in University of North Carolina. I think he retired last year. I'm not even sure if he's half retired, but we worked very closely with him, and those are numbers published by him independently. It is not something that Carestream did by itself. So it is a third party testing this. And you'll see that those numbers can be very comparable to each other between 2D and 3D. Now, before we get to that case, and I promise I'll only be 5 minutes on that case, I want to share, this is just an example of how, and this is my personal pet peeve where you see how often we depend on and we use a full mouth series. We don't even think about the radiation exposure when it comes to a full mouth series. And it actually has a higher effective dose compared to a medium CBCT scan where you see the mandible, the maxilla, the sinuses, the airway, the spine. And with all those, it is even less than the radiation exposure from a full mouth series. Now, before we get to that CBCT scan, I wanted to share this paper with you. And of course, as a disclaimer, please double check with whether it's California or any state that you're in. The recommendation that they specifically share. But this paper or this recommendation came from AAOMR, and then it was confirmed by the ADA, where they state that patient shielding is not necessary anymore, whether it's for 2D, 3D, young patient, adult, pregnant patient, senior patient. So it doesn't matter which patient you're using imaging on. So regardless of the patient, it is not recommended anymore by AAOMR to use lead shielding as routine practice, whether it's 3D or 2D. And you see this as a way, I see this as a way where it's more acceptable and it's more common to rely on imaging for diagnosis, and you don't want that radiation exposure to get in the way of what's best for the patient. And specifically with cone beam, because when it gets to the point where you are taking a CBCT scan, you either have a patient in pain and you want to find out where the pain is coming from, or you need guidance in deciding on treatment plan or the prognosis of a tooth. So either one of these two, you're not just regularly taking bite wings where the patient comes in for a checkup. At this point, there is a purpose for that CBCT scan. Okay, now before we conclude, I'm going to open that CBCT scan. I'm assuming you still see my screen. So this is,
Yes.
Okay, thank you. Thank you, Nicole. So this is a medium field of view CBCT scan where we have the mandible, the maxilla, we have the sinuses. And if you have never used this before, this is what the Carestream or CS 3D imaging software looks like. Yes, you use it with Carestream scans, but you can also download this software for free from the Carestream website. And you will be able to open any scan that is saved as a DICOM. So as native DICOM, there's a few cases where you will see proprietary DICOM. Unfortunately, in those cases, we can't use this software to open the cases. But I think it's very helpful if you are regularly looking at scans and you don't have a machine in your practice. It's good to get used to one software, look at scans using one software instead of spending like 10 15 minutes trying to figure out how the software works before you actually get to the findings of the scan. Okay, now I'm going to focus just on the maxilla, and I'm going to zoom in my findings over here. And what I'm going to do is to scroll. I'm just going to scroll. We're not doing like an in-depth interpretation or anything. We are just scrolling from right to left. And you can see that the purpose of the scan, why it was taken, was to see if there's enough bone volume in those two edentulous sites to place an implant, or do they need to place graft material first. Now, I want to use this scan as an example to look beyond your area of interest, because when you do, it's I know like it's for there are liability purposes, but what is even more important than that is the patient's comprehensive evaluation. So if we are just looking at the maxilla and we start from tooth number 2, I'm actually, well, let me maximize this for a second. And if we look at uh, the findings on this cross sections, we can see it's endodontically treated, and there are 2 low density areas around the APCs of number 2. So at this point, we could be thinking if this is a scar or if it's an active lesion. Of course, we need more information to like when the treatment was completed, is the patient symptomatic? But I can tell you that just from looking at this cross section, assuming the endo treatment was not completed yesterday or last week, this does look like an active lesion, especially with the effect it's having on the floor of the sinus. So you can see the floor of the sinus is elevated, it's thinned, it's interrupted. We have mucosal thickening on the floor. Now, if this were to be a scar, yes, we can have like a similar size or volume around around the APCs of the teeth. But one thing you will not see with a scar is any mass effect on surrounding structure. This means it is an actual periapical rarefying osteitis. Okay, so let's zoom in more. I'm worried this might be too small. If we continue scrolling, we can see we have apical PDL space widening on number 3, especially over here. Now, at this point, we're thinking, is this occlusal trauma? Is there a lesion that it has started to form? And oh, by the way, this is an enamel pearl. So where you see like a globule of enamel within the furcation area, it's usually irrelevant to the patient's symptoms. It doesn't really cause anything except for periodontal problems. So you might see more bone loss around an enamel pearl compared to anywhere else. Now, yes, there is PDL space widening around the patient's teeth generally. So we might want to check the patient's occlusion. And I'm going to jump to number 9, align this, rotate this for a bit so we can see number 9 more clearly, and maximize this again. So as I'm scrolling back and forth between number 9s, you can see that there's that low density area on the buccal surface of number 9. And it happens to be coinciding with where the post ends. This guides us into thinking that this could be a post-perforation, if not certainly a post-perforation. And one of the filters that can help us with eliminating any artifact from the crown, from the obturation material, it's the metal artifact reduction algorithm. So if you look at my left side of the screen, you'll see that we can go back and forth between felt camp and metal artifact reduction. So felt camp is how basically any scan is reconstructed. And you can see there's streaking, there's beam hardening around the crown, around the post. Whereas if I click on MAR, this is all eliminated or at least reduced. So it's like having two scans on top of each other overlapped. And I want you have the option to see it with or without that filter. And seeing that finding and I think I could even see that line horizontally, seeing that finding in both felt camp and with the filter applied gives me more confidence that this is real and this is not just artifact, especially if you're looking at implants. So these are just my 2 cents when it comes to looking at a scan in a comprehensive way to discuss that with the patient. So especially if you are placing implants, you took the scan to place implants, it's good for the patient to know like, okay, I also have these I need to take care of. Are we going to extract number 9? Do you have any symptoms on number 9? Will we place all 3 implants at the same time? Or do you want to take it step by step and see 6 months from now how you feel about it? But having a plan, um, letting the patient know that there is a path, there are more stuff we need to work on, and maybe at least have them prepare financially for it is helpful for the patient. And they would have much more trust in you as their diagnosticians and really rely on what you're saying. So with that, thank you so much for having me on here. Really, it's my pleasure. Thank you for all the Glidewell team. And this is just my last conclusion where I think this picture really represents how cone beam affects our perspective, where we are not just looking at the patient or at the case from our own point of view, but it helps us pause and look at it as a whole to diagnose and not just see what the treatment plan is. Thank you so much. This is my contact information if you need it. And if not, I think we can take questions.
Very good. Thank you, Dr. Al Matny. You know,
Thank
I think most of our attendees understand that when someone comes on that has a great deal of expertise the way you do, that it's very difficult to put together, you know, a 45-minute lecture that's really helpful. And I think you
Thank
did a
you.
wonderful job.
Thank you.
Most of the lectures that I've gone to on 3D imaging have really centered on implants, and you covered a lot of general dentistry, a lot of endodontic issues that I really hadn't thought much about. So let me start the question with really my own question. So, uh, do you have any general comments to make about the quality of endodontic treatment? Like you're seeing endodontic treatment in a way that the person who rendered the treatment often doesn't see it. Do you find that very often, especially in molar root canals, that canals are not well obturated, the canals are not well cleaned?
So yes, especially with root canal treatments that were completed years ago, where cone beam wasn't really used as an adjunct imaging modality. Um, yes, you see sometimes missed canals, and it is not something specific. Like it doesn't. There's no judgment behind for the clinician or their work. It really has to do more with the variations of normal that we have. So it is not every first maxillary molar where the mesiobuccal canals merge. Sometimes they merge, sometimes one exits towards the palatal. Sometimes you see multiple lateral canals. So having that information ahead, like before you actually do the treatment, really like gives you more certainty in what you're doing.
Absolutely, absolutely. I think you gave us some great demonstrations of that. I've had a couple questions here about the case you showed with number 18 and number 19, where they both you know, were actually on number 19, where it went into communication with the inferior alveolar nerve. What was the resolution of that case? We all want to know. Were we
So
able to fix that numbness?
yes, both molars were endodontically treated, and within the next 6 weeks, you could see even you could see the lesion become smaller, and the patient's symptoms went away with time. Now, just as a side note, like with 2D, we used to do a post-op or follow-up uh, when it comes to the size of the lesion decreasing, 6 months to a year. But on cone beam, we now have the opportunity to see and evaluate the volume of the lesion become smaller from 3 to 6 months. So it gives us the ability to have a closer follow-up on what's happening.
Do you think that those lesions were there before the crowns were done?
I think so. Yes. And this is like I have no fact, but I think so. And 30% of the crowns that are placed on vital teeth, they end up having to be root canal treated afterwards. And I think these are because we're not using cone beam to see if there is a lesion that's apparent or not. Yeah, I think so.
Yeah, I bet that doctor wishes he took the cone beam before the crowns, not after. Now it's a great point. These cases that you showed were really well selected, and thank you. I did have a couple of people write in about the changes in the guidelines of shielding patients. Um, I know that you're not required to do anything that isn't part of the overall guidelines, but is it wise? I mean, patients can come down with some kind of lesion and they look for somebody to blame it on and they drag you through the courts even though you haven't done anything wrong. Would you still recommend that doctors do screening? I mean, protection?
So I can tell you that in my 3 year residency, I have not used a lead apron once. We actually packed it, put it in a drawer so patients do not see it. If they don't see it, they don't think about it. And I know, like in private practice, it can be different, but I think with time, with more awareness, uh, uh, to patients, yes, it might become the new normal to not use a lead apron because it has more of a psychological effect than actually protecting the patient from anything. But I also understand that in the meantime, before this comes more common, to take precautions, especially I would recommend like you follow the state guidelines and not just the guidelines that AOMR sends out, because some states take longer than others to say this is part of our protocol as well.
I think that's a great comment. Yeah, look to your state recommendations and maybe even check with your state dental association. That's great. In where you showed the accessory canals and all the different variations of normal anatomy that are seen, it sort of makes you think that that even if you're far away from the inferior alveolar nerve, that you definitely want to take a cone beam anyway before you place an implant, just to make sure there's nothing there, no accessory canals that you could impinge on.
I would. Yes, I would. Yeah,
Okay.
I would. Yeah, and like another variation that we might have is just altered bone pattern. If it's more dense, it's less vascularized, so it affects the integration of the implant. So there are just too many variabilities that you can have simply when it comes to patient's anatomy that can impact your treatment.
Absolutely, absolutely. I just want to ask you one more thing. So you were talking about using different settings based on what specific condition you're looking for. Is that the recommendation you have that, whether when I'm checking on an implant or checking on an endodontic lesion, that I would have different settings for my cone beam?
Yes, yes. And it, that's not really reality. The go-to is like I have, even if my machine takes 14 fields of view, I'm just going to use that specific one. That is more common, but I think for endodontic purposes, to take the smaller field of view, you could high resolution. Um, the parameters that I personally like are 90 kV and 10 MA, versus if you're looking for implant placement, um, relationship with third molars, with mandibular canals with third molars, I would stick to standard to take a medium field of view. And if you're looking for overall evaluation, TMJ, airway, ortho, I think it's a low dose is more than enough.
Well, thank you. Thank you very much, Dr. Al Matny. I think this was a great lecture. I really enjoyed it. Can't wait to have you back.
Thank you.
And we're gonna cover a lot of other topics, and I really appreciate it. And thanks to everyone who joined us today in our panel. And be sure to come back next week when we'll have Dr. Ben Moralia, and he's going to show some or share some insights on aligner therapy and using it to optimize airway health. So let's see you back next week, same time. And thanks again, Dr. Al Matny, for joining us, and thanks to all of you for joining us. Take
Thank
care
you.
and have a good week.